just yesterday, there was a pseudo outbreak of non-tuberculosis mycobacteria that was published that said that, eventually they found out that they had this pseudo outbreak, that the ice baths were contaminating the samples. But they directly talked about, they had over 800 FTE hours committed to this pseudo outbreak. And I think a few, like $80,000 or so of laboratory money spent on this pseudo outbreak, which, if you were doing genomic surveillance, you would have immediately recognized it early on, saw it was a pseudo outbreak, and you would have saved all that just for one single outbreak. So it's a great use case.
Infection stops where information starts. Welcome to the Transmission Control Podcast, where knowledge is your strongest defense. Broadcasting from the front lines of healthcare, we dive into the strategies, science, and stories shaping infection prevention today. Each episode, we connect you with experts on real-world insights to help you stop the spread of healthcare-associated infections, protect patients, and strengthen your practices as an infection prevention and public health expert. When the right information reaches the right people, lives are saved.
Hello and welcome to the Transmission Control Podcast. Today we're talking about genomic sequencing with Alex Sunderman, learning about how we can keep patients safer with whole genomic sequencing, knowing when an outbreak is really an outbreak, and how that's going to inform care for IPs moving forward. We'll be right back after a brief word from our sponsors.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
Hello and welcome to the Transmission Control Podcast. My name is Garrett Hollenbeek, Editor-in-Chief of Transmission Control, and I'm joined today by my co-host, Jill Holdsworth. Jill, how are you today?
I am doing great today. Thanks for having me as always.
Yeah, absolutely. And we're excited for this guest and the topic as well. This is one that, even as the host of the show, I was like, I'm really excited to learn about this topic and to talk with our guest, Alex Sunderman. Alex, how are you?
Never better, Garrett. Thanks for having me on.
Yeah. So for those that don't know you, tell us a little bit about your IP journey and your career and what you're working on.
Yeah, certainly. So my background is public health. So I did my master's in public health and infectious diseases. And that was back in, I get older every single year, 2014. And I did a practicum at that time in infection control. So I worked as a hand hygiene observer. And then when I graduated, I became an IP at the hospital here in Pittsburgh, Pennsylvania, UPMC. And then from there, I got involved with outbreak investigations and other things like you normally do for an IP. And through one of a big outbreak investigation I went through, I decided, I want to go back to school and learn more. So I went back for my doctorate of public health part-time while I was working full-time in infection prevention. And that's really where I got into the gist of my research, which we'll talk about today. But I've since switched to the dark side of academia, and now I work as an assistant professor in the School of Public Health here at University of Pittsburgh. But I still have direct ties to infection prevention because my research works with infection prevention every single day. So I like to say I was always an IP first, and now I work in academia.
So you ran the gambit there, which is good because I think that gives you a good cross-section of both the public health piece and then also the kind of boots on the ground IP work that you do. And that really informs our topic today, which we're talking about genomic surveillance. And I'm probably going to mispronounce it at least 20 times during this episode. I was practicing before we started. But Alex, at a high level, what is genomic surveillance and how does it guide and inform our outbreak response?
Yeah, genomic surveillance is a new technology, and it has to do with the use of whole genome sequencing, which to most audience I'll say is like DNA fingerprinting. And I recognize that not all hospitals are even able to do whole genome sequencing whatsoever. But we have to think about, in the context of IP practice, what do we do right now? So think to when the last time you did an outbreak investigation. Typically, how hospitals and IPs are informed of outbreaks is you have, 10 MRSA cases on a single unit, and you get notified that, hey, we think this could be an outbreak. And you do your investigation as an IP, you make a line list, you start doing audits and observations, you make interventions. And then very few, if any, hospitals have the ability to do whole genome sequencing on those patients' infections, these MRSA infections. Some people use public health labs, some people might work with academic partners, but it tells you, are these patients we're seeing truly the same MRSA, the same pathogen, meaning they're part of an outbreak, or are they not the same and this isn't an outbreak? They still might be hospital-acquired infections. And what most hospitals see is that it's usually not an outbreak, and we call that reactive whole genome sequencing. When these hospitals typically think they have outbreaks, it's usually not an outbreak, and we have data, and others have data to support that. So what we're interested in, on the other hand, and we can get into, is the use of genomic surveillance, which is sequencing patient infections, whether or not you think there's an ongoing outbreak whatsoever. It's new. No one really does it yet, and that's why it's in its research phase, but that's why we're researching it.
I find this completely fascinating because I can't imagine how many people are listening to this thinking, wow, how many times that I wish I had known all of those C. diffs on that unit were connected or not, or if the CRE infections in that ICU were spread amongst themselves or all independent. It seems like this is something that would be so completely valuable. So I want to just ask first, without this, where do you think IP programs could be lacking, or where do you think they are right now? Because a lot of programs aren't using whole genome sequencing, and you said that most aren't doing the surveillance. So where do you think they are right now? And then we can kind of move that into where they would benefit more.
Certainly. Yeah. So, most hospitals don't even have access to this to do reactive sequencing, let alone sequencing everything. But we asked ourselves, what happens in the published studies where people did sequence everything? And we did a systematic literature review and found in every single case, essentially, there is undetected transmission that goes completely under the radar that every healthcare institution is missing. And we took that data and then we started our own first initial phase of our research study, where at our hospital for 2 years, we essentially sequenced all these infections that were in the hospital, if patients were in the hospital for more than 2 days. And we compared it to what our IPs did at the same time frame. And we found over the course of 2 years, essentially 100 outbreaks of about 300 patients that went completely undetected. And then what our infection prevention group thought were about 15 outbreaks of 130 patients. None of them were outbreaks. So we know traditional current practice, IPs are missing so many outbreaks that go undetected. But we're also misidentifying and misallocating all these resources to what we think are outbreaks, but are truly not outbreaks.
So really using that resource allocation could be a reason alone to say this is a great way to use your teams more efficiently. But getting access to the testing, I guess that might be a way to think about it, because like you said, many people don't have access to it. So if you don't have ready access to it, say you don't have a research lab or you don't have a lab that can do it, where would someone send something to be sequenced if they don't have ready access?
We have, thanks to my mentor and PI of our group, 10 plus years of doing this and a laboratory built up, but obviously that's not feasible for everybody. And public health ability to do sequencing is very variable. And the funding isn't always necessarily there, and funding is something we can talk about separately. So I think in the future, it's going to be a combination of public health, academic partnerships, but also commercial partnerships. I'm specifically not going to name any specific companies because I do consult for one, but there has to be some type of commercial solution in the end that will lower the bar for access and availability for institutions to take this on. And I think that's where the direction is going to be heading in the future, is being able to have some automation in all of this, that you don't need to work with your public health department. You don't need to invest in a huge academic lab. You're able to just send isolates to get sequenced.
It's really encouraging to hear that the future landscape looks more kind of formatted and that we have a system to do this. So I want to ask, what are the implications and outcomes of having a really robust genomic surveillance program?
Yeah, I mean, we are more comfortable that we know where transmission is occurring. I mean, Jill, you alluded to that, It's about allocation resources. And one of the major issues that sometimes arise is, why would we, or if we do this, we're going to find so many more outbreaks. Our IPs are already short-staffed. What are we going to do? Well, we know that you're already misallocating a lot of their time into something that isn't really meaningful. So we can better allocate them to doing these outbreak investigations. And through our research, where we've actually been doing it for about almost 4.5 years of weekly real-time genomic surveillance with infection prevention interventions, we show that it's sustainable, but also when we make these interventions, we're stopping the outbreak. So we have confidence that the infection prevention things that we're doing is making a true difference in reducing HAIs, which is sometimes very hard to come by in IP practices. Is what we're doing directly that we can measure making an impact. And this is one of those scenarios where we know that we are.
That's incredible. And can you imagine the impact we could have in long-term care with some of the outbreaks we know are going on there? And if you could say, we know that obviously these are linked, but we can now figure out how to stop it. I mean, it would be an incredible impact.
Yeah,
I want to ask
point, too, about like institution setting of like long-term care. Most of these studies are academic tertiary care centers, but there has to be some added value of long-term care, skilled nursing facility, community hospitals, and that impact is going to be variable, but it would definitely be useful nevertheless.
I do want to ask the question, probably everyone's wondering, is this expensive?
So our academic lab is very transparent. We use all publicly available tools to do our analyses. We do use a commercial partner for our sequencing because it's much cheaper. But we made a preprint that is under peer review right now, under revision, where we go through everything in great detail, including our costs and how we've optimized our costs. So even including the cost of a full-time employees for laboratory and bioinformatic analyses, which is partly the people we need to actually do it. For sequence an individual bacterial isolate for our lab is about $90 an isolate, but we can get it as low as about $50 an isolate, which is hundreds of dollars cheaper than it used to be years ago. And that cost is only coming down as we go forward. And so it's becoming increasingly affordable. That is now making it more not only available for research, but for actual IP practice.
That's fantastic when you think about the hours it could save IPs that they could be doing something else and impacting their work in other areas.
Yeah, there was actually, this is like brand new off the press in the Itchy Journal, Infection Control Hospital Epi. Just yesterday, there was a pseudo outbreak of non-tuberculosis mycobacteria that was published that said that, eventually they found out that they had this pseudo outbreak, that the ice baths were contaminating the samples. But they directly talked about, they had over 800 FTE hours committed to this pseudo outbreak. And I think a few, like $80,000 or so of laboratory money spent on this pseudo outbreak, which if you were doing genomic surveillance, you would have immediately recognized it early on, saw it was a pseudo outbreak, and you would have saved all that just for one single outbreak. So it's a great use case.
And then you think about the intangible piece of it too. When we go to a meeting and we say, all right, there's been 5, positive C. diff cases on this unit. It's looking like a cluster and we're going to need to do A, B, and C. Then that, I don't want to say the panic spreads, but it does to some degree. And how much more confidence could an IP go into that meeting to say, we had, we checked everybody and 3 of these cases are linked or none of them are linked, because we have down to the DNA knowledge about these pathogens.
And
honestly, I love it because you can actually start to say, we need to focus on antimicrobial stewardship instead, because everybody wants to say, well, it must be EVS, and I hate that.
Clean the room.
Right. So I feel like I love C. diff as the example because I feel like that's like the easiest example, but maybe it's antimicrobial stewardship. Maybe it's not EVS. Maybe it's not hand hygiene. But until we did hold genome sequencing, you're just going to keep guessing and throwing everything out there and wasting your resources, to Alex's point.
Oh, yeah. So Dr. Ariana Miles-J out of Michigan did a wonderful study on C. diff genomic surveillance, found absolutely no transmission. So they're like, it's a stewardship problem. And that's something we see here too. And on the other hand, what we see in our own institution, We sequence most of our MRSA. None of them are related. We do have community clusters, so we know it's a community problem. There's a group out of one of the military hospitals that sequenced all of their Group A strep, saw a bunch of clusters, but it was a community outbreak that they saw. So they knew that they weren't having in-hospital transmission, so they felt more comfortable that, this isn't a big issue. We know where it's coming from, and then we can tell our public health partners.
For you to tell us a little bit about how you feel this could be used in scope outbreaks and things that like endoscopy and things like that. I've heard you talk about it before, but I found it fascinating. And I think a lot of our listeners will also really enjoy that.
Yeah. So UPMC, not that you want to be a first in this, was one of the first hospitals in the U.S. to, discover the 2012 endoscope issues as well. So we have this long history with it. Like all hospitals do now. And when we did genomic surveillance without any interventions, not telling our IPs what was going on, we had multiple endoscope outbreaks that went undetected completely. So there were 5, 10 patients large, down to a single endoscope that we weren't detecting. And interestingly, our facility would do routine sampling of endoscopes as well each year as part of routine practice. And we had this endoscope that tested positive for Pseudomonas aeruginosa on the scope culture. And now in review, I think they went back, a month into its use and found no patients with Pseudomonas aeruginosa. So IP practice continued. When we went back and sequenced all of the infections, we found 6 patients, all with genetically related Pseudomonas aeruginosa, all housed on different units, that over the course of about 6 months, all had essentially this endoscope that then tested positive. And that was genetically related to that isolate, meaning that it likely went from patient to patient and used. And because these outbreaks can span months at a time, it went undetected. So it's a great use that, we can identify them. And now that we're doing it in real time, when we have 2 patients with the same infections, because we're doing it in real time, we see that they have the exact same endoscope. We yank it out of service. We'll inspect it. Sometimes we saw issues with it. It failed a leak test. If we can fix it, it goes back into service. But now all of our endoscope clusters are only 2 patients large. It is no longer 5 patients large. So we know we're being effective at now stopping endoscope transmission where it happened frequently.
It's really fascinating. And something just clicked for me while you're saying in real time, because to go back and find those isolates, you're really lucky they still existed and that you were able to test them, because a lot of labs wouldn't even still have those isolates that you could connect all of that together. So to be able to do it in real time is really the best way to go, so that those isolates haven't been discarded and you lose that chance to connect everything.
Yeah, so for the prior study, we would collect the isolates every single week, but we would wait months to actually sequence them because we didn't want to interfere with the study design or, ethically have to inform our IP team about an ongoing outbreak. But yeah, so now weekly, we collect them every single week. We sequence them every single week. It takes about 14 days from the time you, say, take a blood culture to the time you have the results back, which is sufficiently quick enough for bacterial outbreaks to make all these interventions. So I want to emphasize that you don't need next day turnaround time. 2 weeks is plenty of time to actually make a difference.
And this really covers one of the gaps. If anybody's done a scope specific outbreak investigation, it's labor intensive. You've got a whole team of people. You're trying to make sure you don't contaminate any of the samples. It's a long process to get results back. During one, I remember, we're sitting there swabbing the sink and swabbing the cabinets and the surfaces and the countertops and I remember thinking, we're swabbing everything the patient, and so it's closing that loop of saying, all right, instead of environment to environment, which you swab a sink, you're going to come back with everything plus the kitchen sink.
Yeah. And then it leads you down all the wrong paths because, okay, we got 5 things that are normally found in water and contaminated sinks. So is this the answer or not? It really is pointless to swab the sink sometimes.
Yeah. Absolutely. Now, walk us through, because you mentioned kind of the ethical implications. We talked a little bit about the cost implications, but I can imagine, almost hear the audience thinking, well, what do we do with current outbreaks? What do we do with future outbreaks? How do we inform people that they've been impacted? How do we square that circle with genomic sequencing?
That is a great point. Actually, at Shea, this upcoming conference, I have an abstract accepted that also exists as a manuscript and draft on ethical considerations of patient notification and that sort. The CDC has a wonderful guide that they had posted about when to notify patients when they're involved in an outbreak. And essentially, if they have been harmed or their care has been changed, they should be notified that they were part of an outbreak. And now they're CDC guidelines. They're not, enforceable. So from an ethical lens, though, we can use that same type of guideline and say, in these scenarios, they technically should be informed. And I know folks get, really worried about hospital litigation, but a lot of the research has pointed towards that if you're ethically transparent and disclosing, that actually reduces your risk for hospital litigation, rather than the fact when a hospital knows about the existence of an outbreak and withholds that information that might come out later. That is a different relationship. So try to reassure hospitals that have reached out to me that this is not going to increase your chances of litigation, and notifying patients is ethically the right thing to do, which from an operations standpoint, I know can be a big lift, but all in all, it will work out in the end.
I'm glad you brought that up, because then you have the flip side of that coin to say, if you know that your current outbreak process is not working, that we're missing something like 95% of outbreaks, well, then you have the ethical obligation to improve the way that things are being done.
That's a wonderful point. I wrote kind of an op-ed piece in Infection Control Today on that. And again, my disclosure is I'm not a lawyer. This isn't legal advice. But I have talked to some lawyers, casually who have done hospital outbreak litigation and said, what are your thoughts on this? Obviously, it is not standard of care. And the line in which it turns into standard of care is very vague. But eventually, we might get to a point where if a hospital is not doing genomic surveillance and you have an endoscope outbreak of 10 patients, plaintiff litigation could say, if you had been doing this, which is now recognized as effective and sustainable in the literature, you could have prevented all my plaintiffs' infections. And that can actually open you up to litigation in the end. And how we get to that point, I'm not sure. And obviously, we are not there yet. But down the stream, that is a real scenario that could happen.
I just had this thought that when we get to that point, you're going to be called in as like the expert for whole genome sequencing, because you are. So they're going to call you in and say, well, how could this have helped? And
right.
Because you are the face of whole genome sequencing in IP and Shea and APIC. And when people say that, they think of Alex. So that's going to be an interesting time for you when you start getting those calls. Like, can you be the expert witness on whole genome sequencing?
Yeah. And I think it might open up for IPs, because traditionally for healthcare infection litigation, we think of individual physicians talking about, surgical site infection litigation, which is a one-off case. But when we go into more broad scale things about what was done, when did we know, what did we do about it, that becomes an infection prevention issue as well. It's not necessarily just a individual patient healthcare issue.
That is the reality of IP, as the buck stops with us, whether we have control over the situation or not.
Right.
We're there ideally to prevent harm for the next patient. And this is a way to do that. So walk us through the actual workflow of, let's say your hospital rolls out a full genome sequencing program. What does that look like in practice?
Right. And so for us as an academic research lab, it looks a little different than it should, and I think will look for other hospitals that don't have us existing. But what we do as a research lab is every single week we'll query the EHR to say what infections meet our inclusion criteria of bacteria that we're interested in, but also, being in the hospital for more than 2 days, and we want to sequence those infections. We'll do a query, make a list of these are the infections that we want to grab. And one of our research techs will go down to our clinical lab, who we work very closely with, look for those samples, pick them up, bring them back to our research lab, prepare them for sequencing, and then we ship them out to the commercial company we use for sequencing, because they, we're very transparent with, can make it cheaper than we could ever do in-house. And then we'll do our bioinformatic analyses, which has been automated, and we use all publicly available tools and have published it. And then every single week, I get an email that says, Alex, here's all the new outbreaks or new patients this week. Here's some genetic information, that isn't as relevant. And then I'll do an initial review of the patient records to look for commonalities, units, procedures, healthcare workers. And then to optimize our IP's time efficiency, I'll then just email a line list to our infection prevention department and say, here's a new outbreak. Here's an ongoing outbreak with a new patient. And here's a little blurb about where transmission might be happening. And I only send them ones where we see evidence of where transmission might be occurring. And that's all they get is a line list. There's no phylogenetic tree. There's no DNA data. There's nothing else. Because in the end, and I try to emphasize this for IPs, you don't need to know genomics. You don't need to know bioinformatic analyses. You don't need to know library preparation. As an IP, what we need to know in the end is who's in my outbreak. That's it. And that's what they get. So that's the process we do in our hospital.
I'm just blown away and jealous that you have this process and that you have somebody that kind of oversees it, and that it's not the IP department that's trying to figure this out themselves. And I think everybody listening is probably thinking, how do I get an Alex in my hospital? So I don't know if you're able to share, how did you get the support for this, or the financial support? Because I think that you've sold everybody on the fact that we need to be doing this. So what are the next steps for somebody listening to say, okay, how do I get my hospital on board with doing this?
So we are, for the genomic surveillance program, fully NIH grant funded supportive. We do not have internal funding for genomic surveillance. That is a next step in conversation that we're trying to have. To transition it to not a research project, but a real-time patient tool that can be sustained and funded by hospitals. And that's where we're going. So I know that can be a kind of a daunting question about how do we get money for this? And I've had the wonderful privilege of sharing my work with hospitals across the U.S. and even the globe, speaking at conferences. And part of that, I get a lot of feedback from people about their experiences. And through that, I've kind of refined of how is this path going to go forward? Because everyone I have talked to, just like you said, Jill, agrees that, this is where we're going to be going. It's a good patient tool. It's wonderful. It improves outcomes. But when we talk to our healthcare leadership, there's no budget for it. Even though we've shown we can prevent infections and deaths and actually save net costs, we thought more about where is the money savings coming from. The savings is coming from where we're no longer having patients with infections, and the treatment for those infections don't have to be paid for. That is saved by payers and insurance companies. So when we go to a hospital leadership and say, look, we'll save these infections and deaths, but we're saving these monies, the hospital is not saving money. So they would have to put the bill forward and get no reimbursement whatsoever for it. So I think the conversation that we're trying to shift towards is having insurance involvement, where we can either bill for this or reimburse for it or incentivize it. That makes it more sustainable, that insurance companies will save the money, the hospitals will get the patient benefits, and can actually make it a sustainable program that they don't have to put a line item for every single year. The problem with that is education, that insurance companies aren't reading peer-reviewed paywall journal articles that I published. So I think we have to do some type of education to make those types of programs and pilots move forward.
It makes me think of the recent, and it's been just in the last couple of years, where colon cancer screening is a good example of that. Your grandparents will order a colon screening instead of going into the hospital for a colonoscopy. And not only are we reducing the risk of exposure, but it's much more cost effective. And I think those are the conversations that over these next couple of years, I think get more and more common, which is great, because this is clearly a good program, and it makes so much sense when you start to talk about it and think about it.
Yeah, there's the emerging technologies that, come out of research. The one I try to use for an example, it was out west in one of the insurance companies where a hospital found that diabetic telehealth monitoring and check-ins improved outcomes and patient outcomes in the end, but the hospital didn't have the bills to pay for it. So they went to the insurance company and said, would you sponsor a program like this? And they showed great success that, the insurance company reimburses for these telehealth monitorings, the patients do better, the health insurance company saves money, the hospitals see better outcomes. This is that exact scenario. So I think my role as the researcher trying to lead this is, and I'm still trying to figure this out, is who to talk to in health insurance and how do they work and what drives them to get these types of programs sponsored and out there.
Love it. Now, one question that I think we want to cover is when you send that line list to the IP, what do they do? What's their course of action? Next steps once they know that there's an outbreak?
Yeah, so we have about 8 IPs at our 700-bed hospital. I think we're at 8. Don't quote me on that. But they do a round robin kind of assignment. So, they assign out outbreaks, and as an IP, you're assigned to the outbreak regardless of where a transmission is occurring. And from there, it's their responsibility to affirm that route of transmission I said makes sense, that Alex isn't crazy, but then kind of make a plan of action from there about the interventions. And a lot of it is really education, outreach, talking to the unit director, talking to the bedside nurses, working with environmental services to make cleaning enhanced at that time, which we know can work really well. Removing devices or medical devices, or talking about medical devices and how they're cleaned. And then importantly from our end and from an implementation end, documenting what they did, when they did it, who they spoke to, which helps them make sure that they're doing what they need to do. But then it helps us from a research side to say, is what we're doing effective? And that's kind of a win-win scenario. So they do weekly check-ins too as a group about, does anyone need help with their outbreak that they're investigating? Because typically in a single week, we'll have at least one outbreak or cluster of 2 patients that will get assigned. So it's relatively frequent that we see this happening.
Thank you for walking us through that. I think that's what makes it practical. It probably puts some fears at ease for IPs to say, once I know this information, what am I doing with it to keep patients safe? Well, Alex, as we round out this episode, any words of wisdom or go-and-dos that you would share with the audience for how they can improve outbreak practice or make this genomic sequencing program a reality?
Yeah, to go back to the funding issue, I don't want to say like all hope is lost that you can't do this unless insurance is paying for it. But I want to humble myself and try to ease maybe people's imposter syndromes that you don't need to be an expert in genomics or outbreak investigation to advocate for a tool like this. I have never run command line to do bioinformatic analyses. I have never done library preparation to do sequencing. If you showed me like the raw genetic DNA, I don't know what to do with it. Like, you don't need to be an expert in order to advocate for your hospital to want to bring this in. You can read some of the literature, some of the commentaries that are out there that I've tried to be more accessible for the lay person about what the technology is, and then use that and then still try to advocate for some sequencing capacity for your own hospital. So I don't want to think that just because you're not a genomics expert, you're not an outbreak expert, that this is inaccessible. It's still there. And as an IP, though, the IPs are going to be leading the way about advocating for this, because without IPs, it's not going to make any difference whatsoever. So I really want to try to emphasize that to the people who are listening, that you can do this. We're all starting from square zero here, but to try to encourage you to reach out to your healthcare leadership to try to adopt this.
That's awesome.
Love it. Yeah. Well, thank you so much, Alex, for sharing your insight and expertise and for bringing something to the forefront of the conversation that would be really impactful. So we want to thank you. Thanks, appreciate you having on.
Thanks, Bill, too. Thanks.
Thank you. Well, Garrett, I don't know about you, but I could have honestly listened to Alex all day long. I found his work and what they're doing at his hospital is so fascinating and so beneficial for that IP team. I'm honestly jealous of them that they get that kind of information. They're going to truly know how to stop outbreaks in their tracks and really allocate their resources to more appropriate tasks. I just think this is really what the future of IP is moving to. So I honestly can't wait to see what is next for Alex Sunderman and for whole genome sequencing. This is going to be really exciting to watch over the next few years.
Yeah, it is. And it's one of those things that after you hear about it, you're like, why aren't we doing this already? Why isn't this standard of care? Because when we think about the resources that are allocated to tracing down an outbreak that may not be an outbreak, this is the type of solution that really makes patients safe. So we're very grateful to Alex for providing his expertise and really showing how we can do things better in the next couple of years. To all of our audience members, definitely go check out Alex and some of the research that he's put out there. We're grateful to you for joining us on the podcast today. Remember, infection stops where information starts.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.